22 years old. She is a housewife and was admitted on January 8th, which is 1 month ago. She came in complaining of generalized body swelling for 7 months and difficulty in breathing for 4 days. So DW was well until 7 months ago when she started experiencing swelling, which began on both her lower limbs and proceeded proximally. It was gradual and associated with fatigue. She sought treatment in KUTRH, where she was admitted twice. That was 2 weeks in October and 8 days in December. She presented on January 8th in Kenyatta with worsened symptoms of generalized body swelling and difficulty in breathing for 4 days. So the generalized body swelling was on both the lower and the upper limbs. She had abdominal swelling as well and facial puffiness. The swelling progressed in a gradual fashion, starting from both lower limbs and ascended proximally, affecting the arms and finally the face. She did not have any chest pains, any paroxysmal nocturnal dyspnea, but she had orthopnea and palpitations. She did not have pale stools, no yellowing of the eyes or itchiness in the right upper quadrant. She had oliguria prior to admission, no hematuria, no dysuria, no lower urinary tract symptoms of frequency, urgency, nocturia, weak stream, straining, and emptying. And the color of the urine was straw colored. Difficulty in breathing, we classified it as New York Heart Association Class 3, meaning there was marked limitation in physical activity. She didn't have any cough, she didn't have chest pain, and there was no wheezing. She didn't also have a history of diabetes, no history of fever. She didn't have any calf pain, and she didn't have any history of hypertension prior to admission, as well as alcohol or cigarette use. On past medical history, she didn't have any history of surgery, no asthma, no known food or drug allergies, and no history of blood transfusion. Obstetric history, she is para 1 plus 0. She delivered last year, February 2023. It was a normal delivery. Her last menses were May of 2023. Prior to that, they were regular, coming after every 30 days. They lasted 3 to 5 days, and she used 45 pads, and the flow was regular without any clots. Family social, she is married. She has one child. NHIF is active. The father passed on earlier in her life. Her mother and all her siblings are well, and they haven't had a similar event or ailment in their life. On systemic review, CNS, GIT, and musculoskeletal were all okay. There weren't any significant findings. So summary, DW, a 22-year-old, presented on January 8th with generalized body swelling for 7 months and difficulty in breathing for 4 days, associated with oliguria, no palpitations, orthopnea, cough, or chest pain. And there isn't any stigmata of chronic liver disease.
Okay, Dr. Thank you very much. Before you continue, we'll just have a small comment regarding what has been presented. You'll realize, as of now, before you go through the general examination or any other systemic finding or any other laboratory problem, a young girl, 22 years old, with an asaka and difficulty in breathing, isn't it? So, and by the time he has captured in the review that predominant symptoms are just that we don't have any stigmata of chronic liver disease, she doesn't have orthopnea. The essence here is that we have 3 organs that every time you see somebody who is fluid overloaded, that you always think, which by now should be at your level basic education, that either there's a problem within the heart, there's a problem in the liver, or there's a problem in the kidney, isn't it? So by the time somebody is giving a clue that we don't have orthopnea, we don't have PND, there's no stigmata of chronic liver disease, whatever the colleague is mentioning is that we are narrowing down to something that is not the heart, not the liver. So even before you conclude, and probably if we didn't have a topic, then we didn't know what we are discussing, you realize, okay, we're coming to a conclusion that this is probably a problem within the kidney. Carry on, Dr.
So we are now in our general exam. The patient was seated, propped up in bed, not in any obvious respiratory distress. She didn't have jaundice. She was pale. There wasn't clubbing. There wasn't any cyanosis. She did have edema of both the upper, lower limbs, abdomen, and facial puffiness. There wasn't any lymphadenopathy, and she wasn't dehydrated. On the systemic exam, for the abdominal exam, on inspection at both the foot and the side, there was movement with the respiration, and there was also presence of stria. On palpitation, on superficial palpation, there wasn't any tenderness, and there wasn't any obvious masses on deep palpation or any organ enlargement. On percussion, there was fluid thrills and shifting dullness. On auscultations, vowel sounds were heard. On CVS systemic exam, uh, she was warm to touch. There was normal temperature. There wasn't any peripheral cyanosis, no genuine lesion, and no ocular nodes. There was facial puffiness. There was pallor, and there wasn't any central cyanosis. There was bipedal edema, and the pulses, this is the radial pulse, the rate, rhythm, and volume was normal. When it comes to the precordium examination on inspection, there weren't any chest deformities, no scars, and there was symmetry. On palpation, the apex beak was present. On auscultation, S1 and S2 were heard. On investigations, the WBC count was 9.16, platelet count was 191, and the hemoglobin was 9.0 grams per liter. On our urinalysis, there was proteinuria, there was hematuria, the nitrite was negative, and the leukocyte was negative. On urea electrolyte and creatinine, the urea was 28.12 millimoles per liter, which was increased. The creatinine was also increased at 279.4 micromoles per liter, and there was hypoalbuminemia of 20.1 grams per liter. The parathyroid levels are also increased at 191.4 picograms per micromole. The total PSA count was at 0. Ferritin was at 321.27. On KUB ultrasound, there was the loss of corticomedullary differentiation, and there was increased renal parenchymal echogenicity. So the current medication she's on and management, she's on Lasix, Clexane, nifedipine, prednisolone, aldactone, azathioprine, lactulose, carvedilol, omeprazole, empagliflozin, iron sucrose, and erythropoietin. She was also told to decrease salt intake. She's on daily weight management, and she was given nutritional counseling. So for the general principles of management when it comes to nephrotic syndrome, we usually have the definitive and the supportive treatments. For definitive treatment, we have prednisolone, that is for steroid-sensitive nephrotic syndrome. And for supportive treatment, we have Lasix, which takes care of the edema and that spacing. The Clexane is for thrombosis prophylaxis. The nifedipine and carvedilol we give because of the secondary hypertension. The omeprazole we give to counteract the side effect of prednisolone, which causes damage to the GIT mucosa. The iron sucrose and the erythropoietin are for the anemia, which came about because of the decreased erythropoietin. And usually monitor the treatment by doing daily weight monitoring and urine input-output, and we monitor the blood pressure regularly.
We have a few things that needs to be very clear at the beginning and at the end of this discussion. In as much as we are having a discussion on nephrotic syndrome, I just want you to realize that the patient that we have so far seen from one of our patients in Kenyatta does not necessarily capture everything that we expected in someone who has nephrotic syndrome. So please do not be misguided at the end of the discussion that this is the typical patient for nephrotic syndrome. There is quite a huge overlap between nephrotic and nephritic. If you get the patient towards the very end, when probably the disease has progressed, you will end up seeing a patient with chronic kidney disease, and you may not meet that young, innocent patient with nephrotic syndrome at the beginning of the disease. So a few things that have I want, before I go to the meat of the discussion, just from the history. When you look at the investigations that were done, you notice the WBC, fair enough. The platelet, normal. What do you notice about the HB for 22-year-old? Slightly on the lower end, isn't it? Okay. Look at the urinalysis. We have proteinuria, 3 pluses, and then we have blood. Okay. Anytime you notice this thing, one of the things that you need to ask the patient before you say that, okay, this could be a disease whereby I'm having a pattern of nephritic thing, you ask, is the patient in her menstrual period? Okay. Very important. It's very misleading most of the time. So if you don't capture it, you'll think, okay, this is a mixed pattern. That needs to come out very, very clear. And then it's not a clear thing for people with nephrotic syndrome to have a picture of hematuria. So diseases do not read books, as they always say. There is a possibility of an overlap, but you do not expect hematuria when you have a pure nephrosis, okay? Leukocyte negative, no problem. The thing that is also very important to be captured, look at your urea, look at your creatinine, okay? At the beginning, so you'll be surprised that, okay, do we have a patient who has got a nephrotic pattern, but also has an AKI because of fluid or, third spacing? Because when you have significant edema, what happens to your intravascular volume? It becomes less and less and less, isn't it? And then eventually, you're not perfusing the kidneys, and then you get a bump in your urea and creatinine. It's not a pattern that is very common in nephrotic syndrome. So what am I coming to? Look at your parathyroid hormone. Is actually high, okay? And then finally, look at the ultrasonographic findings that we have a corticomedullary loss. Not a common thing in nephrotic syndrome, okay? So this is an idea that probably either this person has a nephrotic syndrome that has progressed, and now we have a chronic kidney disease pattern, or we have a concomitant nephrotic syndrome and something else that is giving the chronic kidney disease. It's not unusual for nephrotic syndrome to progress to chronic kidney disease, okay? So if you had followed up, this young lady was diagnosed with nephrotic syndrome at the beginning. Once you follow up, because they tend to respond to steroids, but they recur. So every time there's a recurrence, there's a loss of kidney function, you eventually end up becoming an end-stage renal disease patient requiring dialysis. Are we together? Okay. So if you were to give one diagnosis in this patient, the diagnosis will not be nephrotic syndrome, in as much as we're discussing nephrotic syndrome today. Because this is just to give you an idea of how the patient presents. You may not necessarily see the classic patient, and then we'll discuss towards the very end. Okay. So now let's begin our discussion. Nephrotic syndrome, what is it exactly, and what are we dealing with? What is the setup? How common is it in our country? How does it present? What are the causes? And how do you manage? That is what we will be discussing today. As you have seen by now, probably in your school, nephrotic syndrome is a clinical syndrome. The diagnosis is not made by one specific lab or a radiologic feature. It's a clinical syndrome that has a few things. Number one, you have a low albumin. So hypoalbuminemia is the first marker, the first feature of nephrotic syndrome. The second thing is, when you lose your albumin, and we will discuss the pathophysiology, what happens to the body? You have a reduced oncotic pressure, you get third spacing, you get fluid overload, so you get edema. It has nothing to do with periorbital edema. It can be anything, but the common thing that students tend to see is periorbital edema, but you can see edema anywhere. So the second thing is edema. What is the third feature that we was not captured here? Is your cholesterol level. So you have hyperlipidemia, you have high cholesterol levels. What is the fourth feature? Low albumin, edema, cholesterol. What's the last one? Nephrotic range proteinuria. So that is what is captured, because we don't have an extensive evaluation. Those 3 pluses, the easiest way of making a conclusion is every plus is more or less a gram of protein, okay? So when you have 3 pluses, you can easily deduct, not accurate, that this patient has lost 3 grams, okay? So anyone who has those features, low albumin, anasaka, high lipid, and a nephrotic range proteinuria, that person has nephrotic syndrome by definition, okay? There's a 5th feature that is added by the KDIGO, but it's not a common thing and it's very difficult to assess, is a hypercoagulable state, okay? So that's more of you cannot clinically say that this person has hypercoagulability, but it's also a feature because of the loss of antithrombin 3. So basically what in terms of your pathophysiology, the problem with nephrotic syndrome is where exactly? Is it a tubular problem? No. It's what? It's a glomerular problem, okay? So every time you have fluid within your Bowman's capsule, it has already been filtered, okay? So that filter that we have there is already taken care of by number one, an intact glomerular basement membrane, an intact food processes, and the fact that we have the negative charge of the glomerular basement membrane optimized and already intact. So in people with glomerular diseases, whether it's nephritic or nephrotic, they tend to have a leaky glomerular basement membrane. So what you see, for example, if we have a huge protein with high molecular weight like albumin, albumin usually is not supposed to be filtered, isn't it? Number one, albumin is not necessarily high, has a large molecular weight, but the problem with albumin is why is it not filtered? It's because of the negativity. So we have a negative charge, and then we have a negative charge within the glomerular basement membrane, it's repelled. So people with glomerular diseases, specifically the one that is common in this pediatric age group, not pediatric but the younger one, minimal change disease, you have a glomerular disease that is not necessarily found from a clinical exam. You have to do a biopsy, okay? So you have a porous glomerular basement membrane that is leaking, not necessarily albumin, but so many other proteins, okay? So that's number one. Number two, so once you lose your albumin, what happens? You reduce your oncotic pressure, you have edema. And number three, as a feature, you have high cholesterol level. Why do we have high cholesterol level as a feature in nephrotic syndrome? The exact pathophysiology is not yet clear, because when you go through so many things, it's not that we have an evidence that has been confirmed that this is because of a specific thing, but the hypothesis is when you lose a lot of albumin, what does the liver try to do? The liver tries to compensate by producing so many proteins. One of the proteins produced by the liver and other features is your cholesterol. So you get a lot of cholesterol produced by the liver in compensation, in desperate compensation. So you get a high cholesterol level. The fourth one is now when you look at your protein that is being lost, you get a nephrotic range proteinuria, meaning you lost more than 3.5 grams in 24 hours. Okay? It has to be more than 3.5. If it is not 3.5 and above, you do not have a nephrotic range proteinuria. Okay? So how do you quantify and say, I already have a 3.5? The urinalysis is not a good way of measuring it. We have two ways. Number one, you can do a urine albumin creatinine ratio. It's actually done here in most of our places. And then we have a urine protein creatinine ratio. Remember, when we are quantifying, we are saying it has to be 3.5 of not albumin, but protein. Okay? So if you can get a urine protein creatinine ratio of more than 3.5 in 24 hours, that is by definition nephrotic syndrome. Okay? However, if you don't have it, let's say, for example, you have a protein that has reached 6 grams, but you don't know whether this is albumin, because the protein could be albumin, number one, which is the predominant one. It could be something else entirely different. Okay? It could be light chain for patients with multiple myeloma, or for patients with amyloidosis. Okay? So the best way is, most of the assays that we do it here, you can easily actually quantify and say, specifically, look for light chain, look for this, look for that. But if by definition you have a protein more than 3.5 grams, that is nephrotic range proteinuria. Okay? So once you have those four features, that patient has nephrotic syndrome. Okay? So what causes nephrotic syndrome in commonly in our setup or globally? What is actually the commonest cause of nephrotic syndrome worldwide, just to be precise? Do you think it's one of the primary disorders? No. The commonest cause of nephrotic syndrome worldwide is actually diabetes. Okay? It's actually diabetes, because diabetes will give you all those features. It will give you low albumin, it will give you anasaka, you get high cholesterol, and you have nephrotic range proteinuria. So it's actually diabetes. The secondary causes is by far the commonest one. And then in terms of the female patient who are within the reproductive age group, it's actually preeclampsia. Okay? Preeclampsia is actually the commonest cause of nephrotic syndrome. And then now you come to your primary causes, whereby you have either a minimal change disease or an FSGS or membranous nephropathy. Those are the primary ones. And primary basically means is there's nothing else going on in the body. You don't have diabetes, you don't have preeclampsia, you don't have anything else. Your heart is intact, liver is intact, but you have a young girl at the age of 22 coming with a picture of nephrotic syndrome. So what do you do most of the time? You just throw a dose of steroids, because it is known that minimal change disease is very responsive to steroids, okay? So sometimes, because you may not necessarily be a setup where you can readily get a biopsy. So just by the patient responding to steroid is actually a good sign that this person has minimal change disease. So minimal change disease basically means is you just do a biopsy. Within the light microscope, you usually don't see anything. That is why it's actually called a minimal change disease. It's very common in the younger population, and it has a very good prognosis because it tends to respond to steroids. But the terrible thing with minimal change disease is recurrence. So you give a course of steroids, the patient responds, goes home 6 months, 9 months down the line. While on steroids, they're actually here with a flare. So probably you will pulse, or you'll have to get something else that is different. That's number one as a primary cause. The second primary cause is membranous nephropathy. So we say the layers is we have a capillary layer, we have a glomerular basement membrane, and then we have the food processes down there. So when you have a very thick capillary basement membrane, that is also what is likely to be causing as the second primary, which is membranous nephropathy. Okay? It's different from membranoproliferative. It's different. The only difference is when you look at the biopsy, there is no hypercellularity with membranous. So the other one, the reason why it's called membranoproliferative is because there is hypercellularity. And that one usually tends to give you a nephritic pattern. Please, when I say a nephritic pattern, the only difference from nephrosis is because number one, you have a picture of an element of hematuria, and number two, you have uremia or deranged UEC is a little bit of an AKI, and number three, you have high blood pressure. When you have those three, that is a nephritic pattern. When you have these ones, that is a nephrotic pattern. When you have both of them together, you get a mixed nephritic syndrome. Okay? And the last one is, in terms of the primary that is common, is FSGS. Not common here, but common worldwide. In Kenya, what will your guess be? What is the commonest primary one? Minimal change disease. Minimal change disease because of that, our age group. So FSGS, when you have a focal segmental glomerular sclerosis, what do you think is the underlying primary problem? Sclerosis, but what exactly is leaking? What exactly is causing the proteins to be lost? Still, we have a problem with your food process. But this time around, what is giving us a terrible problem is we have an element of some immune complex deposition. So you have a leaky still. So what they all share is they all call podocytopathies. So you have a problem with your podocytes. Okay? So that is your primary. Minimal change disease, membranous nephropathy, FSGS. Can you look at somebody and say, no history of diabetes here, okay, no preeclampsia, I can bet this person has minimal change disease? Are there features you can easily say, like, okay, this person most likely has membranous nephropathy? Without doing a biopsy, is it easy? No, it's not easy, but we have associations. We have associations. For example, if you have somebody with a solid tumor, lung cancer, colon cancer with nephrotic syndrome, what is it likely to be? Which one is associated with solid tumors? Membranous nephropathy, okay? So these associations are very common. For example, if someone who has a HIV, heroin user, which one is likely to be? FSGS, okay? A young patient in our population group with nothing else, who is a school-going children, most likely a minimal change disease. So those associations are key, but they also tend to overlap. For example, someone with non-Hodgkin's lymphoma or Hodgkin's lymphoma could as well be having a minimal change disease, okay? So that's why we tend to say, okay, solid tumors, but not necessarily the hematological malignancies. Okay, another key association is there's a test that you can easily do and say, okay, I will not do a biopsy because this procedure is a little bit, invasive. The outcomes are not always. Sometimes you can actually biopsy a part of the kidney that is innocent, we have nothing, and then you don't get any problem. Especially that's why it's called focal segmental. So if you're not hitting where the problem is, you just get a clean biopsy. There's a lab test that you can do and say, okay, if it is positive, this person has membranous nephropathy, for example. Anyone who is familiar with a lab test? Okay. No, a lab test. Immunofluorescence, we are staining it after you've done a biopsy. So you can do, like that biopsy from the kidney is where you're subject to light or electron or immunofluorescence. That is a tissue biopsy. Without an invasive procedure, a lab test that you can do, say, okay, this patient likely has a membranous. I'm actually giving the clue. I'm not saying minimal change disease. I'm not saying FSGS. Okay. There's a test that has been out actually for a while now. It's called anti-phospholipase A2R. Is the antigen that is predominantly found in patients with membranous nephropathy. So if you have an antibody against phospholipase A2R, there's a 95% sensitivity that this person, without even doing a biopsy, is likely to have a membranous nephropathy. And then if you find membranous nephropathy, and then you just look for a few key associations. And the reason why the biopsy differences is important, we'll mention it when we're discussing the management. Okay? So far up to there, is there something that needs to be clarified? You can ask a question. The video might not necessarily project you, but your voice will be heard. Up to there, are we together? That any clarification? Okay. So having mentioned that this is a disease that can easily be divided into a primary problem and a secondary problem. And the secondary problems are many, but in our setup, just know that diabetes is a common one, worldwide, also here in Kenya. And then preeclampsia. So if you find a young girl who's had multiple, episodes of admissions, and then you tell them, okay, we had a recent delivery, this is AKI HELP syndrome, and she is actually overloaded, and you do your blood urine protein levels and its nephrotic range, preeclampsia tends to come faster than anything else. Before you think this is minimal change disease or FSGS, think of preeclampsia, think of diabetes, because diabetes is a common thing in this setup. But once those two are not there, those are now the things that probably you say, okay, we will give you a course of steroids, but you'll come for a biopsy. Why is a biopsy important? If, let's say, most of them, you will be giving them some steroids. Why does a biopsy make a difference? Because number one, the prognostication is very essential. For a patient with membranous nephropathy, usually a third will respond, a third will respond and recur, and then the other third will actually progress. Okay? So when you have a clear indication, say like, okay, I have a membranous nephropathy, part of the discussion when you're trying to treat this patient, you'll have to give them some steroids, but you tell the family members, okay, this disease is likely to recur. You might actually end up requiring renal replacement therapy, either with a dialysis or a kidney transplant. So you prepare for it. So the biopsy is essential in number one, prognostication, and number two, in terms of the management, which we will see it. Okay. Nephrotic syndrome, how do you evaluate a patient who has got nephrotic syndrome? You have a clinical diagnosis of nephrotic syndrome from the low albumin, the anasaka, the high lipids, and nephrotic range proteinuria. How do you evaluate this patient before you do a biopsy? There are a few things you need to do. Number one, in our setup here, you have to do an anti-nuclear antibody. Okay? Because SLE is a common disease in the female age group, and it gives you, there is a possibility that you can actually have a diagnosis of nephrotic syndrome just caused by SLE, or nephrotic syndrome caused by something else, or a nephritic pattern. So anytime you have somebody with a nephrotic pattern, as you're trying to evaluate for the causes, what do? You do an anti-nuclear antibody. Okay, that's number one. Remember, when we're evaluating, we have evaluated with the things that has already given us the diagnosis. So we have done a urinalysis, we've done a UEC by my assumption, we've done an LFT, we've done an albumin that is low, we have done a urine analysis, either by just a dipstick, and we have approximated the loss of protein, or we have done a urine albumin creatinine ratio or a urine protein creatinine ratio, and we have a high meaning we have anything above 3.5 gram. And please, we are not doing the 24-hour thing collection. That's a bit, it used to be there before, but it's a bit difficult. So right now, by just getting a sample and getting a ratio that's more than 3.5 gram, that basically means that if you collected for 24 hours, this person will lose more than 3.5 gram. Okay? So you have an anti-nuclear antibody done, SLE confirmed or not confirmed. So if you have an ANA that is positive, you will entertain a diagnosis of SLE or any other connective tissue disease. because connective tissue diseases are possible causes of nephrotic syndrome. What is the other thing that you can easily do in your evaluation? Triple serology. Yes, in our setup we call hepatitis B, hepatitis C, and HIV. We lump them up together and call them triple serology. So patient with hepatitis B or C or HIV can give you a nephrotic syndrome. But when you do the biopsy, that's when you can see, okay, they are likely to give you a membranous pattern or an FSGS pattern, okay? But in the setup, when you have just seen the patient, triple serology is an essential evaluation for anybody with nephrotic syndrome. What's the other thing that you will do? If, let's say, let me make it a scenario. So an elderly man above 65 years old with no history of diabetes, with low HB, who has a nephrotic pattern, low albumin, nephrotic range proteinuria, hyperlipidemia. What are you thinking about? You're thinking about multiple myeloma, okay? So multiple myeloma, the light chain deposition can easily destroy your glomerular basement membrane, and you start leaking proteins, and you get a picture that is nephrotic. By now, I'm sure it's a bit clear that nephrotic syndrome is a clinical diagnosis, but the causes are many, okay? The causes are many. So by the time you're saying this person has nephrotic syndrome, doesn't necessarily mean it ends there. It's probably secondary to diabetes, secondary to HIV, secondary to SLE, secondary to multiple myeloma, okay? So getting the diagnosis of nephrotic syndrome is one, but getting the definitive cause is the second step. So we're just trying to evaluate and say, okay, number one, I have a diagnosis of SLE, a diagnosis of multiple myeloma, and so on. So what is the other thing that you will do? You have done an ANA, you've evaluated for multiple myeloma. What is the safest, easiest way to evaluate for multiple myeloma? Oh, sorry? SPEP, UPEP. So the serum protein electrophoresis is what you can easily do, or the urine, but the serum one is very easy, and a free light chain assay, but it's not actually something that you need to bother yourself with. If you think there's a diagnosis of multiple myeloma, just from the initial features where you've seen your calcium is high, your creatinine is high, the patient has got anemia, and there's a picture of nephrotic syndrome, you can easily say there's a differential of multiple myeloma and send it to a hematologist or hemato-oncologist. But if you are at the setup when you can easily evaluate, you do a serum protein or a urine protein electrophoresis, okay? What else can you do in terms of your secondary evaluation for nephrotic syndrome? ANA, let's say normal. Diabetes, you've done a HbA1c, normal. This patient is not within the reproductive age group, or this is just a gentleman, you don't think about preeclampsia. What else can you do as a potential cause of nephrotic syndrome? Yes, amyloidosis, I have mentioned it earlier. So amyloidosis is also a potential diagnosis of multiple myeloma, and it's a systemic disease. So if the beta amyloid is being deposited anywhere, it can actually give you a destruction. So if it gets deposited within the kidney, you can get a destructive process, start having a leaky glomerular basement membrane, and you start getting a picture that is entirely of nephrotic syndrome, where you have all the features that we have earlier mentioned. So, okay, when you do all those things and you don't have a single diagnosis that is obvious, is when we tend to do a biopsy here. But ideally, a biopsy needs to be done right off the bat. If you're in a setup where you can easily find and you have an access to a biopsy, it's good to get a biopsy right off the bat. In a setup where you cannot do it, you can easily now look for these other screening things, causes that are less invasive, and then you get a tissue diagnosis afterward. Now you go straight to a tissue diagnosis, is when now you say, okay, I have a minimal change disease, or I have an FSGS, or I have a membranous nephropathy from a biopsy, okay? We have, for example, in FSGS, we have a focal segmental glomerulosclerosis reported, because most of the time, it's not you as a doctor who is reporting, it's a pathologist. Or we have a thickened glomerular basement membrane with no hypercellularity. This is a membranous one. Or we have a minimal change disease. We have minimal changes on a light microscopy, but we have a few specific changes that are not always available on electron microscopy, and you can conclude because of the age group and say this is a minimal change disease. Okay. All right. So how do you manage somebody who has come with a nephrotic syndrome? For example, you have finished all your initial evaluation. You have taken care of the few screening diagnoses that you can easily make. Say, okay, no SLE, no diabetes, no history of HIV exposure, and your triple serology are negative. You have a diagnosis. Let's say, for example, these are the, because once you have a secondary diagnosis, managing it is easy because your target is more or less managing the secondary cause, isn't it? But for example, you have a primary cause. And primary cause basically means before even you do the biopsy, just by screening for potential secondary causes, there's nothing that you've found. So number one, so now let's make sense of what we've had in this patient and see what we can easily add. When you're managing this patient, just put in mind what we've had at the beginning. Every single clinical syndrome needs to be managed at some point, okay? Because if the patient is presenting in one way, your treatment is aimed, number one, at being supportive. And then the second thing is now when you say, okay, I can look for multiple myeloma or something else. So number one, so let's say the first feature was what? Hypoalbuminemia, isn't it? We have a low albumin. Will you give albumin? For example, look, do we have albumin in this patient? Last 6, we have clexane, we have nifedipine, a steroid, aldactone, azathioprine, lactulose, carvedilol, a PPI, SGLT2 inhibitor, iron, and EPO. Will you give, let's say, maybe lactulose, dietary salt intake? Okay. Will you give albumin because your patient has low albumin? Okay, so the initial thought process in the school of teaching was albumin was playing a very key role. But when you realize that there is a porous glomerular basement membrane that is already making you lose the albumin that you've had. When you give albumin, what happens to that albumin? You'll make a very expensive urine, isn't it? So you lose all the albumin in urine. So right now, albumin is not the answer for nephrotic syndrome. That is actually the thing that needs to be clear at the beginning. But if you get very, very low albumin level, and that very is not a clear thing among nephrologists, so it's usually something that is dependent on whoever is handling the patient. If an albumin that is 5 or 7 or 8, and you feel like there's too much third spacing, you can give, but it's not something that is really agreed upon in terms of its utility in the long term, okay? So low albumin, you choose to give it if it is extremely low, but the beauty about most of these, the ones that are responsive to steroids, is by just giving them prednisolone, for example, the person that you've seen 3 days or 4 days or 5 days ago is not the same as who you'll see. All the puffiness and everything has responded just by giving them a dose of steroid. The second thing is now, okay, so you have third spacing that is significant. You have, just like our patient, we have bipedal edema, we have a dyspnea that we thought probably could be because of pulmonary edema, because if your third spacing, where does fluid go? It can go to anywhere, isn't it? So if it goes to the lungs, you get pulmonary edema. Sorry. So once you have a difficulty in breathing, that is already an obvious indication for diuresis. But just because of a patient who is puffy already, with lower limb swelling, a diuretic has a role. So you give a loop diuretic in this setup is the one that is of choice. So you give a Lasix, 20 milligram, 40 milligram, 60 milligram, depending on how puffy the patient is and depending on the weight of the patient. So the second step of management is a diuretic, and the whole idea is to dry up the patient. What's the third thing? Remember, we had a few features. Number one, low albumin, we have taken care of it depending on the patient, though it's not a clear thing as a management. Second thing is we have diuresis. We have cholesterol levels that are high, isn't it? So what do? We give a statin, okay? We have a statin in this patient? Fortunately, no. So we have mentioned that the features is hyperlipidemia is a feature. So if there is hyperlipidemia, for example, your total cholesterol is high, or maybe just the LDL is high, that is by itself an indication for a statin therapy, okay? So you give Lasix, you give albumin depending on how low albumin is. Third thing is you have to give a statin. What's the fourth thing that you will do in your setup? Will you give an ACE or an ARB? How many are for ACE, ARB? Remember, you said most of you guys are final year, isn't it? How many are given ACE, ARB? Only 2 people are confident enough. How many are not given S or ARB? No S, no ARB. Have I lost you people? Are you guys not following what I'm saying? Anyway, what does an AS ARB do in the real sense actually? What do they do? Remember, you have an afferent arteriole and you have an efferent arteriole and then you have a glomerular intact, isn't it? So what usually is a potent vasoconstrictor of the afferent arteriole? What vasoconstricts at the beginning? No, afferent, what vasoconstrictor afferent? What causes an afferent vasoconstrictor? Afferent, I don't want to mention it. Okay. What is a potent efferent vasoconstrictor? Angiotensin 2. The afferent one is usually the NSAIDs. That's why they're terrible drugs. Okay. So because they are reversing the role of prostaglandins. Prostaglandins cause what? Afferent vasodilatation. Okay. So the efferent arteriole is usually vasoconstricted by angiotensin 2. It is a potent constrictor both, but it's predominantly on the efferent, isn't it? So when you give an S and ARB, whose role are you reversing? The angiotensin, isn't it? So whenever you give angiotensin inhibitors or the S inhibitors or the ARB blockers, you are reversing the role of angiotensin 2 that is a potent vasoconstrictor of the efferent arteriole. So if you have vasodilated at the efferent, what are you trying to do? You are reducing the net intraglomerular pressure because you require pressure for anything to be filtered. Okay? So if there is so much pressure within the glomerulus, we have glomerular hypertension, you tend to filter so much. Okay? So if you are losing a lot of protein, part of it probably because of the podocyte that was leaking or the glomerular basement that has lost its negative charge, and part of it is because of the glomerular hypertension. So the idea here is if we vasodilate the efferent, we will reduce the intraglomerular pressure and we will reduce the net effect of anything that is being filtered. So the filtered load will be small. Okay, makes sense? However, remember even creatinine, which is a byproduct, it's predominantly filtered, okay, and then partially secreted. So when you give an ACE inhibitor or an ARB to a patient, you tend to see that there is a bump of creatinine and urea immediately post-administration, okay? So that's why you will be told, okay, if we had an AKI, we did not give urea and creatinine. So this patient, my assumption is because we already have a high urea, high creatinine, even if we were to benefit from the net effects of ACE and ARBs in decreasing the interglomerular pressure and decreasing the proteinuria, but because of this setup, they will worsen the acute kidney injury and we will not use it, okay? However, if the patient did not have an acute kidney derangement, the urea and the creatinine were normal, and you had a nephrotic range proteinuria, there is a very good role of an ACE inhibitor or an ARB. Together? Okay. So what's the other thing that you're managing? You have given Lasix, you have given albumin, depending on what school of medicine you tend to follow. You have given a statin, you have given an ACE or an ARB. Up to there, is our patient okay now? We can watch. So what's the next thing we'll do now? Now, more of a definitive thing. Which drug? A drug from here. Choose one drug there. Whose money, yet you'll bet your money on it that this is the drug I need to give. Lasix, Clexane, Nifedipine. It's a steroid, come on, okay? It's a steroid. Now, because we haven't biopsied the patient yet, but remember what I told you at the beginning, a good number of the patient, it cuts across, whether it's membranous, whether it's FSGS, whether it's minimal change disease, they tend to respond to steroids, okay? And the one that tends to respond to steroids most is your minimal change disease. So if you have a patient, especially the young patients, you give them steroids right off the bat. So that if there is a very good response to steroids right off the bat, you can easily make a conclusion without necessarily having a biopsy that this is likely, not yet confirmed, likely to be minimal change disease. And then you confirm it by doing a biopsy, okay? So you give a steroid. Supposing it was not a minimal change disease, it was membranous, it was confirmed. For example, this person has had this problem before. A biopsy was done a long time ago. The biopsy result comes to you. You see, okay, this is nephrotic syndrome, but I have a membranous pattern. What do you do? And you have, and let me finish the question. and let's say you have a kidney injury with a urea that is high, a creatinine that is high. In those patients, you have an option of pulsing them with a methylprednisolone together with cyclophosphamide. Okay, those are the old drugs that have been used for most of these primary problems, membranous and FSGS, and they tend to do well, because the reason why pulsing is important is if this person's kidney function was okay 3 weeks or 4 weeks ago, the urea was normal, the creatinine was normal, and then 1 month down the line, urea is twice the upper limit of normal, creatinine is 3 times the upper limit of normal. If you don't pulse them, the chance of them progressing to a kidney disease that is urgently requiring dialysis is very high. Okay? And the indications for dialysis in that setup is, of course, number one, you tend to have metabolic acidosis, you tend to have hyperkalemia, or because they are overloaded, refractory fluid overload. Refractory basically means is they have come, you've given them a dose of Lasix, but if they're not making urine, what happens? You can't diurese, isn't it? So this patient still remains puffy, fluid third spacing, gets pulmonary edema, and then requiring hemodialysis. So the whole idea is to make sure that you avoid the indication for dialysis by getting any of the indications that are common, that is hyperkalemia, acidosis, fluid overload, and the likes. Okay? What is the sixth now step of management? We have mentioned a few, number 5 or number 6? The sixth one. So what else do you do? We have now given definitively a prednisolone if it is a minimal change disease, or if it's confirmed FSGS or membranous, we pulse them with methylprednisolone together with cyclophosphamide. Okay? Now what is the next thing you'll do to this patient? Let me just give you an idea. Lasix we're given, isn't it? So what are we, the second thing there is just looking at you. Clexane, isn't it? What did we mention about this patient? They tend to be hypercoagulable because of the loss of antithrombin 3. So you can easily get a young lady who has been managed with nephrotic syndrome in the ward, and then 5 weeks down the line, she gets a DVT or she gets a renal vein thrombosis. Okay? They have a hypercoagulable pattern, so you need to make sure that you anticoagulate them. The exact indications for anticoagulation is not a confirmed, let me say confirmed. It's not something that is clearly agreed upon by nephrologists. The KDIGO guideline tend to have a more exclusive criteria. Okay, if you've had the nephrotic syndrome pattern, you are obese with a BMI more than 35, or you have a history of thrombosis, those are the patients you tend to give them anticoagulation. But if you want to be safe, because most of the time it's easier to avoid some of this disaster, you can easily put the patient on Clexane, given that this is a hypercoagulable state. So you finished all those things. The patient is now well anticoagulated, well diuresed. You've given a steroid. The albumin level is not bad. You have given an S or an ARB depending on your kidney function, and you're planning the patient for biopsy. So let's see, most of these other drugs, which one can easily be used? Will you give azathioprine right off the bat? No, it's steroid sparing. So let's say the patient has not responded or they're on follow-up, that's what happens. And this is a decision made by a nephrologist. You do not have a problem with it. Lactulose, if this patient tends to have constipation, fine. Carvedilol and nifedipine, if we had a picture, for example, a minimal change disease, the way I mentioned earlier, and this patient had a trouble, was pulsed, comes back, probably now the disease is progressive. And now once you have a progressive disease, what happens to your kidneys? And what is, by the way, the commonest complication of chronic kidney disease is actually hypertension. The moment your kidney starts losing its function, your blood pressure tends to rise. So these are antihypertensive medications that probably were not there at the beginning, but if you see them in a patient who's already have an underlying glomerular disease, is a disease that is progressive. So that's when you use them, but if the blood pressure is okay, you do not need to use them. The drug that I'm coming to is an empagliflozin. The SGLT2 inhibitors. What's the role of an SGLT2 inhibitor in a patient with nephrotic syndrome? Like let's say, given the case we've discussed, not necessarily nephrotic syndrome in broad, but the case we've discussed. The case we've discussed, the utility of an SGLT2 inhibitor here is number one, from all the cardiovascular outcome trials that were done, Anybody who you think has a disease, kidney disease that is likely to be progressive, you use an SGLT2 inhibitor. Just like they are part of the Fantastic Four for people with heart failure with reduced ejection fraction. Okay, so anybody with heart failure with reduced ejection fraction, SGLT2 inhibitors, beta blockers, ACE on ARB, and aldactone or spironolactone is actually what is used. Even here, just like the ACE inhibitors and ARBs, they have some element of antiproteinuria, and they actually have a nephroprotective effect by decreasing the progression of the kidney disease. So this young lady here had a urea that was high, creatinine was high, though we have not quantified her EGFR. She gets the SGLT2 inhibitors. However, if there was no urea and no creatinine that were high, right, at the beginning you will not start an SGLT2 inhibitor. Okay? And then the EPO and the iron sucrose is if you have a patient with nephrotic pattern whose HB is low, and you think probably this is a chronic disease, this is now where they come to be of help. But at the beginning, in a patient with nephrotic syndrome, you do not give an iron sucrose or EPO if the HB is okay. All right? What is an EPO? Maybe I'm just assuming. Oh, this is an erythropoietin that is produced by erythropoietin comes from kidneys here. So when people who have got kidney problem, the assumption is like, okay, maybe we don't have an erythropoietin that is stimulating erythropoiesis. You give them twice weekly, once weekly, 4,000, 2,000, depending on how low the HB is. Sorry? Other? Okay, so we're almost winding up. Just one final point in this definitive care. The daily weight monitoring is an easy way of trying to quantify how much urine that you're making. Okay, so if the patient comes at the beginning fluid overloaded and with, let's say, 55 kgs, and then the second day you're getting 54, you're getting 53, that's a good sign that you're making enough fluid loss. But if the patient has 55 kg at the beginning and then you're adding them every single day, in as much as probably maybe when you look at it, because probably you want to see a change, in your subconscious level you might assess and say, okay, this patient looks better. But one objective way of saying that you have done diuresis, either you have an urine output that is being monitored, or you get a weight loss that is being quantified every single day. The nutrition counseling is very essential just to make sure that what food are we avoiding here? Anything that is high in salt, so that you do not get worsening of your edema. Okay? Unless there's anybody with a question, I will stop there. Yeah. Yeah. Yes. Yeah. Yeah. That's a very excellent question. Remember at the beginning what I mentioned is we were discussing nephrotic syndrome, but our case wasn't a classic nephrotic syndrome case. Anytime you are assessing a patient that you think this person has a problem with the kidney, let's say this is nephrotic syndrome or just an AKI or a chronic kidney disease, yes, it is good, number one, because kidney diseases are usually staged, isn't it? So every single patient that you probably think has a chronic kidney disease and you want to evaluate and say you want to see the progression, yes, you need an EGFR. And we usually use an EGFR because it's an estimated one. You're not 100% sure. And the reason why it's an estimated one is because your creatinine, see what is the ideal substance that it needs to be used as a marker of clearance. We want something that is 100% filtered, not secreted, not reabsorbed, isn't it? But because of the creatinine is usually secreted, it's not an ideal marker. So we usually call it an EGFR, an estimated GFR. So nowadays we use a CKD epi as a calculator. We don't need, Zaman we used to use like, okay, 140 minus age, divide, no. It's like CKD epi medical, we just insert the creatinine level, it will give you. Yes, it is important, you say at the beginning, I had an EGFR that was normal, 90 and above. So now I have an EGFR that is 20. This is a progressive disease. So yes, it is needed. Even for you to say that this disease is progressive, that is the first thing you usually look at. Second thing is now is your proteinuria. So if you had given steroids at the beginning and there was no proteinuria, or it was there but it was not nephrotic range, let's say you're given 1 gram in every creatinine, and now 7 months down the line you have an overt proteinuria of 8 gram in 24 hours, 12 grams, that is also a marker of progression. Yes, those two things are needed. You can also quantify the progressive of the disease by you look at markers of chronicity, your WB, your HB, and then you do an ultrasound. Are the kidneys shrunken? Is there loss of corticomedullary differentiation? All those things are markers of progressive kidney disease. But something that is very simple, EGFR and proteinuria, yes, you need, and it will be very helpful.